Okay, we're going to do Chapter 41, Anti-Tubercular Drugs. Talk about that as tuberculosis or TB. It's caused by Mycobacterium tuberculosis is the bug we're talking about here. Anti-tubercular drugs treat all forms of Mycobacterium. We find this commonly, or most common, as lungs is considered the primary site for TB, but we can also see TB activity in the brain, bone, liver, kidneys, and the GU tract. How is this transmitted? It is passed from infected person to infected person by droplets. Um, so humans, it can also go between species as well. But these tubercular bacilli, we learned bacilli are rods, are conveyed by droplets. So that is why a TB patient is on reverse isolation and droplet precaution. Droplets are expelled by either coughing or sneezing, somehow aerosolizing respiratory fluids. It is then inhaled by the next person. Those tubercular bacilli are then spread to other body organs via the blood as well as the lymphatic system. We can call TB, when it becomes encapsulated or calcified, it can become dormant so that we won't see it as active TB anymore. When it is dormant or walled off or calcified by thick tissue or fibrous tissue, we would call that latent TB. Latent TB means it's basically under control. We don't see it. It's perhaps in that person's body, but they are not suffering from the effects of it. Latent TB can become very active if we immunosuppress our patient. So let's be on the lookout. It's very similar. We might actually see a decrease in TB spread, perhaps, with so many people wearing masks. But you can see the patient on the right would have TB. They cough it. It's out in the air. The droplets are moving, carried by wind, carried by force, whatever it might be. And the next person would inhale that and then become infected as well. Ways to identify TB. You have a box in your chapter, chapter 41, box -1. Some, again, just ways in which TB looks: a chronic cough, fever, anorexia, hemoptysis or bloody coughing, night sweats, fatigue, weight loss, and chest pain. Two different ways that we can test for potentially TB. In the United States, we use the PPD or the Manitou test. Some places are now requiring, again, that two-step. More internationally, we see the BCG test, which actually will leave a fairly large scar, kind of circular in nature, on a patient's arm. And again, the BCG is actually a vaccine-based concept to try and build immunity towards TB as well. We can see these kind of waxes and wanes in the incidence of TB. From the 1950s, again, that kind of post-World War, where, again, lots of herd lines were crossed. We saw a big rise in TB across the nation. Then it decreased until about 1985. Again, TB came back more as that kind of opportunistic, immunocompromised incidents in patients that were also infected with HIV. There was sort of a resurgence in 1992, and again, that may have been the Gulf War, or just, again, more shifting, unknown as far as why that happened. And then in 2012, that seems to be the lowest recorded rate since the 1950s, and perhaps even more of a decline we'll see in the future. The problem now, again, just as we talked about, are bacteria. We see tuberculosis bacteria also morphine and becoming multi-drug resistant as well. Um, so our most common delivery of TB medication is isoniazid, INH, and rifampin are kind of the number one go-to. TB affects about 1/3 of the population, and then we can start seeing some multi-drug resistance TB that is now both um, non-responsive to our first-line medications, again, isoniazid, INH, and rifampin. And then we are also seeing some extensively drug resistance. That's the X, extensively drug resistance TB. It is rare, thankfully, but it is being seen again in patients who are severely immunocompromised and those who have AIDS. So the bug is morphine and unfortunately becoming drug resistant or more drug resistant. Again, those first line drugs that we see on the left, and a secondary drug list that you can see covering multiple drug classes, including you can see again some of those fluoxetins, mycins, so even stretching into our antibiotic classes. Always the goal of the therapy for TB is essentially to reduce the cough. The cough is the infectious aspect. So if we can get the cough under control, then we can get the droplets under control and hopefully reducing community spread. Most cases, again, of TB can be cured or become encapsulated, again, in that kind of calcified fibrous tissue area. Successful treatment, however, can last 6 to 12 months. So very important that a community health nurse or I just blanked on the name. You guys know, help me out. Health services nurse follow up with a patient that has been diagnosed with TB because of the duration time of TB treatment, as well as the difficulties with some of the drug regimes. Patients have a high time or a difficult time with compliance. So things that we want to not only assess in our patients is compliance, so we will be following up regularly with them. As far as treatment, we also want to be checking in on some of those adverse effects. One of them being specifically numbness and tingling. Okay, we want them to keep taking their isoniazid against that first line treatment. We want to make sure we are killing that mycobacterium. So we take it for the full course. It is metabolized in the liver, so a patient that may be considered a slow acetylator may have to have a lower dose of INH because they would be at risk for hepatotoxicity. So acetylation, again, is a metabolization process through the liver. Some people are genetically prone to something called slow acetylators or slow acetylation, and therefore they would have to have a different dose of isoniazid or INH. They can be used again alone or in combination, especially if they have some sort of resistance showing to our first line drugs. Again, it can be contraindicated with liver disease because of that metabolism. And again, that adverse effect that I spoke about on the previous slide are those peripheral neuropathies. And they are known to happen with isoniazid. So we definitely want to assess our patient who may be struggling with them, because we can give them something for it to help with compliance. What can we give? Does anybody know? It's in there. It's a vitamin. It's a good vitamin. All right, we'll talk about it then. If the prescriber has ordered collection, make sure you understand when and how to do a sputum collection. Again, it's that early morning. You get that thick, kind of gnarly stuff out of their throat. That's the sample we want. It's got the most bacteria in it. And again, it's usually for three consecutive mornings to see basically how much it is. And then when the INH is taken by a slow acetylator, again, how um, uh, that does not break down appropriately because of the liver enzymes, and then you can again become toxic because of it. There it is, vitamin B6 may be indicated to prevent neuropathies related to INH. Um, An improvement should start within 2 weeks of starting drug therapy as far as the patient feeling better and not hopefully coughing as much. Again, hopefully not sharing or spreading their germs. Very similar on some levels to any sort of respiratory spread, as we've kind of all just gone through. It would be kind of a 2 week stay at home, keep your people that you could have coughed on at home, doing some, sort of self isolation to really let those drugs get on board within that 2 week time frame. Reduce the cough, reduce the droplet spread.